This conference will now be recorded.
ये ऑन है, ये चल रहा है. बिस्मिल्लाहिर्रहमानिर्रहीम. I invite Dr. Azizur Rahman for Tilawat Quran. أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. يا أيها الذين آمنوا اتقوا الله ولتنظر نفس ما قدمت لغد واتقوا الله إن الله خبير بما تعملون. ولا تكونوا كالذين نسوا الله فأنساهم أنفسهم أولئك هم الفاسقون. لا يستوي أصحاب النار وأصحاب الجنة أصحاب الجنة هم الفائزون. لو أنزلنا هذا القرآن على جبل لرأيته خاشعا متصدعا من خشية الله. وتلك الأمثال نضربها للناس لعلهم يتفكرون. तर्जुमा. ऐ ईमान वालों, डरो अल्लाह से और हर शख्स देख लेगा जो उसने अपने हाथ से आगे भेजा, और डरो अल्लाह से किया तो अल्लाह ने उन्हें अपने आप से गाफिल कर दिया. बेशक यही लोग फासिक हैं. बराबर नहीं हो सकते जो जन्नत वाले और दोज़ख वाले. बेशक जन्नत वाले ही कामयाब हैं. अगर हम इस कुरान को नाजिल करते
LRBT. Today I will be presenting a series of cases on periocular swellings. A patient 14 years of age presented to our outpatient department on 18th of April 2026 with the presenting complaint of painless swelling near the outer aspect of the left eye since childhood. Upon taking history of presenting illness, the swelling had been present since early childhood. It was gradually increasing in size. It was progressive in nature. It was causing mild mechanical ptosis in the left upper eyelid. However, there was no redness, discharge, fever, or trauma, and there was no associated diplopia or visual disturbance. Her past history regarding facial trauma, any previous systemic or ocular surgery was insignificant. There was no history of glasses, lasers, injections, or surgeries in the eye. Family history, allergy, and addiction history were also insignificant, and the patient belongs to a lower middle class family. Examination was also unremarkable. On ocular examination, her best corrected visual acuity was 6.6 in both eyes. Extraocular movements were intact and full in all gazes bilaterally. Pupils were round, equal, reacting to both light and accommodation. The right eyelid and conjunctiva were within normal limits. However, the left eyelid showed a supralateral swelling that was associated with mild mechanical ptosis. Anterior segment and fundus examination were otherwise normal in both eyes. Local examination of the swelling, it was soft to firm, 4 into 4 centimeter, soft to firm cystic swelling, non-tender, non-pulsatile, having a smooth surface with negative transillumination. The temperature on the swelling was also normal. So the swelling was not associated. The swelling was freely mobile over the underlying structures and was not attached to the overlying skin, indicating of a benign lesion, suggestive of a benign lesion. So on our basis of a history examination, we get the following differential diagnosis: dermoid cyst, epidermoid cyst, lipoma, mucocele, lacrimal gland cyst, glioma, and pleomorphic adenoma, which is a rare case. So a contrast enhanced CT scan of the orbits were done that revealed a 1.7 centimeter well circumscribed lesion over the left superior temporal region. You can clearly appreciate there is no associated calcification or intracranial extension. So our most probable diagnosis came to be left orbital dermoid cyst. So the plan was the surgical excision of the cyst under general anesthesia. So upon doing the pre-operative anesthetic evaluation, which came to be within normal limits, we proceeded for the planned procedure. Here's the perioperative picture of the cyst, of the dermoid cyst, and here you can clearly appreciate the in toto excision of the left orbital dermoid cyst. The wound was closed and the patient was discharged on topical antibiotic ointments after complete recovery from general anesthesia. Here is another interesting case in which it was also a case of left orbital dermoid cyst in which during perioperative manipulation, the cyst got ruptured and toothpaste-like, you can clearly see the toothpaste-like sebaceous material that came out of the cyst. In such cases, management is very important in order to prevent complications. Alhamdulillah, we managed the case and there was no complications post-operatively. Sebaceous debris was all removed, and post-operatively there were no complications. This patient presented to our OPD. This patient got her left orbital dermoid cyst excision done from elsewhere 3 years ago and presented to us with the complaint of periodic swelling near the left periorbital region. So the most cause of recurrence is incomplete excision of the cyst because the epidermal elements that get trapped continue to secrete the keratinaceous material, leading to the periodic swelling. So what are the complications that can occur if a cyst get ruptured? It can cause severe inflammatory reaction, orbital swelling and redness, pain and tenderness, formation of granulomas, scarring, fibrosis, eye movement restriction, proptosis, visual impairment, and recurrence, as we have seen in the third case. What are the recent advancements in the treatment of periorbital dermoid cyst? In patients who are unfit for surgery, sclerotherapy has emerged as a safe and good alternative in which a sclerosing agent is injected into the cyst, which causes inflammation of the cystic lining, which leads to eventually fibrosis and thrombosis of the thrombosis of the swelling leads to shrinkage of the swelling. Another thing is in teenagers and adults where complete excision of the cyst leads to periocular hollowing. In such cases, retroorbicular oculi fat is transposed to the hollowed area to address the post-excisional volume deficits. Here is the brief summary of the literature that is being reviewed during the preparation of this presentation, which suggests the key highlights that I have already discussed. Thank you so much.
In the name of Allah, the most merciful, the most beneficent. Ladies and gentlemen, I am Dr. Taqwa Tariq, Associate Ophthalmologist from LRBT Multan Road, Lahore, and I welcome you all in our prestigious institute. Today, I am the moderator of this session, and this was our youngest resident, Dr. Huzaifa Tahir, who just presented our first case. For the next case, we have Dr. Muhammad Azizur Rahman, who is presenting to us a case of cloudy vision with a hint of copper. This is a case after ocular trauma.
किस डायरेक्शन में लगी? Assalamu alaikum. My name is Dr. Muhammad Azizur Rahman. Today we are going to discuss a case in which I chose the title Cloudy Vision with a Tint of Copper. Our patient, 19-year-old male resident of Cohort, came in our OPD with a complaint of gradual loss of vision over the period of 6 months. Past history revealed that he is an electrician by profession. Visual loss was gradual and over the 6 months, and there was a history of trauma while working with an electric wire. The wire was presumed to be copper in nature. Past ocular history was insignificant other than the treatment of trauma in a localized clinic in his own city. Topical medications were given, which were discontinued upon pain relief after 2 weeks. Past medical history didn't reveal anything significant. No family member has any complaint of any ocular diseases. Examination revealed that in the right eye, the vision was only hand movement with a good perception of light in every quadrant, while the left eye vision was 6/6. Adnexa and anterior chamber examination was unremarkable. However, the cornea shows a deposit superiorly and inferiorly at endothelial level. Gonioscopy examination was unremarkable. Relative afferent pupillary defect was a negative. Crystalline lens in the right eye show sunflower-like patterned opacity, in which if you can appreciate, here you can appreciate that there is a central opacity with spoke-like pattern, which is typically presentation of in case with the copper intraocular foreign body, sunflower cataract is present. Here is the next slide, which shows that, in which we can appreciate the presence of superior limbal intraocular deposits. Here, the inferior limbal deposits can be appreciated. The slit lamp view examination showed that these all deposits were present at endothelial level. Gonioscopy examination revealed that no intraocular foreign body is present at any at inferior angle, and there is also no foreign body present at superior angles or any kind of copper deposits. There was vitreous condensation in right eye. Left eye vitreous was quiet. Fundus examination of the right eye revealed a fibrous band over posterior pole with yellow pigmentary deposits or a golden metallic sheen extended from disc to the macula. Left eye fundus examination was within normal limits. Here is a picture of fundal examination. Here you can appreciate that although it's a bit blurred due to the presence of cataract, but you can appreciate the golden metallic sheen extended from disc to the macula, and a fibrous band like projection that is also present can be appreciated in the brightness scan I'm going to show you next. Here is the picture of brightness scan. You can appreciate the fibrous band extending from the disc. Next is the ocular coherence tomography scan. Here you can see that in the right eye, the gross macular atrophy has occurred, RPE degeneration and photoreceptor degeneration has occurred, and there is only 125 micrometer thickness of central foveal thickness is present, while compared to the left eye, which is around 209 micrometers. ERG reveals all of the right eye reveals that is the left eye and this is the right eye. It reveals all the rod response and cone response. Every response was gradually quite reduced and remarkably reduced. Autofluorescence again show hypo and hyperpigmentation, which also point out toward the gross macular atrophy. Our top differential diagnoses were calcosis bulbi, Wilson disease, ocular sidrosis, drug-induced toxic-retinopathy, and retinitis pigmentosa. Wilson disease was ruled out as neurologically patient was quite sound. There was no Kaiser fascia rings. Ocular sidrosis was ruled out as due to the presence of intraocular foreign body nature, as we have already known by the history. Same with for the drug toxicity, and there was no history of night blindness or retinitis pigmentosa was also ruled out. Our top provisional diagnosis was calcosis bulbi in the right eye. Our treatment plan was, first of all, macular function supportive dietary supplements were given. Cataract extraction was planned, but prognosis was explained to the patient, and patient refused, so it wasn't done. And we advised the patient to use polycarbonate protective glasses to prevent further work-related trauma, as he has only one good eye. Early post-op treatment revealed no significant improvement in visual acuity. However, after 4 months, the visual acuity was improved from hand movement to counting finger. There was a mild anterior chamber activity. Other findings were consistent with the previous examination. Here, if you can see and compare the photos of both eyes, it was 4 months before, and after 4 months, due to gradual absorption of the pigment deposition, now the cataract is reduced, and maybe this is the reason for an improvement of visual acuity, and there is no superior or inferior limber deposits now. However, macular function is still remain the same. The macular atrophy is still the same. No change in that. Thank you everyone for your time. Yes sir. सर इंट्राओकुलर फॉरेन बॉडी उसकी नहीं थी मिली असल में जो उसने 6 मंथ्स बैक उसको ट्रीटमेंट हुआ था और वो जस्ट अपॉन पेन रेजोल्यूशन के ऊपर उसने वो स्टॉप कर दिया देयर वाजंट नो इंट्राओकुलर फॉरेन बॉडी वाज
electric shock that leads to electrician any electric shock basically that leads to a necrosis of the macula and hypermature cataract
सर हो सकता था लेकिन पेशेंट ने कंप्लेंट की थी कि वो वायर काट रहा था तो वायर से पीस उछल के आंख में लगा था और आंख में चला गया था और उधर लोकल डॉक्टर ने उसको ट्रीटमेंट तब दे दी थी और वो सर मे बी स्मॉल पीस था जो अब्सॉर्ब हो गया yes that's why I said that our top provisional diagnosis not definitive diagnosis
so you should also keep differential electric shock retinopathy that causes retinopathy as well as hypermature cataract जिस तरह इस पेशेंट में हुआ
yes sir
that's
सर दूसरा उसमें
Sir, could there be a possibility that the foreign body was actually in the lens? Lens के अंदर हो सकती है.
There could have been a possibility, but it wasn't revealed on examination, and patient refused for cataract surgery. So we cannot definitely say that it was present or not.
very interesting
to find out the foreign body आपने उसका CT स्कैन नहीं करवाया
सर सीटी स्कैन का उसकी रिपोर्ट्स बैक की थी जिसके अंदर कोई पॉजिटिव फाइंडिंग नहीं थी सीटी स्कैन वाज नॉर्मल सर उसका सीटी स्कैन हुआ था पुराना उसके अपने एरिया से लेकिन उसके अंदर कोई इंट्राओकुलर फॉरेन बॉडी की सिग्निफिकेंट रिपोर्ट नहीं थी क्लियर करा दिया हुआ दैट्स व्हाई आई सेड कि आवर प्रोविजनल डायग्नोसिस वाज दिस नॉट डेफिनेटिव डायग्नोसिस सर ये जरा इसको दोबारा स्लाइड शो पे जरा ऐड करिए मैं इसको दोबारा स्लाइड शो पे जरा डालिएगा सर वो भी उसकी वर्बल हिस्ट्री है कि 6 महीने मोमेंट जब पेशेंट बोलता है कि 6 महीने तो उसको 7-8 महीने भी गुजर सकते हैं सर अगर सिटी स्कैन पे एक चीज नहीं है तो आई डोंट थिंक एक्सरे के ऊपर आएगी
ऑनलाइन के लिए
सॉरी सर
I'm bit hard of hearing now, so I'm wearing my hearing aid. I think I have missed something. And you can correct me if you have all mentioned. Now, this is a case where we are talking of intraocular metallic toxicity. Metal piece.
Sir, no, unfortunately, we did not.
We did not.
We did not.
any entry wound
Entry wound on the was around the sclera mark, bit swelling was present, but after 6 to 8 months, the swelling is also subsided.
What investigation you do to find a piece of metal?
So there was a previous history of CT scan of the patient done, and he did not have the films at the moment, and only the report which revealed that there is no significant finding or any foreign body on the CT scan.
बेटा जो आपकी फाइंडिंग है ना कि एंडोथेलियल पे डिपॉजिट्स आपने दिखाए
बिल्कुल
हैं,
सर
आपने एक ट्रैक भी दिखाया है, उसकी फोटोग्राफ अगर आप क्रिटिकली देखें तो वो ट्रैक कहाँ से आया? trauma, non-contact trauma, या there was a foreign body जो उसका ट्रैक है. So the things remain is कि हमारे से वो foreign body locate नहीं हुई. I think we need to do a little hard work. Unless we do that one, we cannot claim that this is the pathology. Claim तो evidence पर होना है. Evidence हमारे पास कोई नहीं है. तो pathology जो है आजकल बहुत advanced है. तो रेडियोलॉजी में they can do enhanced printings and find out if it was. अब तो हो गया जो भी होना है. लेकिन because it's a unique thing. You have mentioned 2 people from India who has published reports like that. So it's a good thing and very good effort that you find it out here. और उसके बेसिस पर ही अब उसको गो फॉर द नेक्स्ट थिंग. एक हमारी क्लिनिकल ऑब्जर्वेशन है जिसे हम कहते हैं कि ये कॉपर से रिलेटेड है. एक हमारी आनी थी केमिकल एविडेंस कि हम वो मेटल ढूंढते, उसको इन्वेस्टिगेट करते कि ये वाकई कॉपर है, ठीक है ना. तो वो हमारे पास दोनों चीजें नहीं है. बहरहाल इट्स अ गुड थिंग. यू हैव डन वेरी गुड हार्ड वर्क. थैंक यू.
Thank you.
So, this was Dr. Aziz. Thank you, Dr. Aziz. Next up in line, we have Dr. Hashim Zubair to discuss a series of cases and management of ectopia lentis.
Assalamu alaikum. I'm Dr. Ali. Today I'll be in a series of which presented Assalamu alaikum. I'm Dr. Ali and today I'll be presenting a few cases of ectopia lentis which presented to our hospital. First, we'll briefly discuss what is ectopia lentis. It is the malpositioning or displacement of the natural crystalline lens from its normal position broadly into subluxation, in which remains in the pupillary view, and the crystalline lens moves entirely away from the pupillary axis, either vitreous sometimes or into the anterior chamber. In each case, we took history of every patient, including perinatal history, which included prenatal, natal, and postnatal histories, history of any glasses or refraction or patching, and family histories of. Coming to systemic history, we took detailed cardiac history, skeletal history, and neurological history of each patient, and any history of any unexplained death at a young age in the family. Clinical evaluation, which included cycloplegic retinoscopy, refraction, and subjective refraction, along with detailed slit lamp examination, including anterior segment and posterior segment exam. We did routine investigations such as A scan, B scan, and ultrasound biometry. And now I will discuss the cases one by one. 4 different cases discussed and each of them operated upon by a separate. First case was a 7-year-old child with supratemporal subluxation in the right eye. Done was lens aspiration followed by insertion of an intraocular lens. This is the video of the the main incision is being made and the capsular access is being done, which will be followed by aspiration of the lens band. The capsular tension ring is being implanted, but as you can see, it will not achieve centration. So ideally, in this case, what has been done was addition of a segmental or modular, but due to its unavailability, we sutured the standard CTR to the sclera, and the centration followed by implantation of the lens. The second case was a 20-year-old person with traumatic of the lens in the right eye. As you can see, it was a shareguard branch. We proceeded to phacoemulsification with the capsular tension ring implantation followed by IOL implantation. Was successfully achieved and vision improved to 6/18. Case was a 35-year-old adult with gross temporal lens in the left eye. As you can see in both the illumination as well as the lateral illumination. Also somewhat developed. Doing emulsification with CTR insertion, implantation of the IOL. In this case, due to the gross subluxation centration post-op, and as soon as the viscoelastic is inserted, there will be a prolapse of the anterior vitreous phase on the main mode. The anterior phase has prolapsed, which will be cut off, and since this patient was left aphakic, scleral fixation of IOL has been planned for this patient in the near future. This is the summary of pre and post-operative visions of all of these cases. Satisfactory vision was somewhat achieved in all of them except for the last one. But however, this patient was also achieving 6/18 vision with aphakic correction. Briefly, we'll discuss the different surgical treatment options available for ectopia lentis. They include pars plana vitrectomy with lensectomy, routine cataract extraction with anterior vitrectomy. IOL placement techniques are also variable, including anterior chamber IOL placement, iris claw or iris suturing of the IOL, or scleral fixation of the IOL. Ectopia lentis can present with multiple complications due to which there should be a close coordination with supra specialities like glaucoma clinic or cornea specialist. Complications include amblyopia, endothelial damage, chronic iridocyclitis, pupil block, angle recession, and complete dislocation of the lens into the vitreous, leading to tractions and retinal detachment. There should be a meticulous post-operative and rehabilitative care for these patients, which includes regular follow-up it should be ensured that patients are using their anti-glaucoma medication regularly after, as you know, pupil block is very common in these patients, and close coordination with medical specialists like rheumatologists and orthopedic and cardiac surgeons should be present, as there are many systemic associations. Concluding our presentation, if the lens subluxation is marked, the procedure of choice should be pars plana lensectomy with vitrectomy. If the subluxation is mild to moderate, we can proceed with endocapsular procedures along with the CTR insertion and IOL implant. If centration is achieved, then well and good. If not achieved, then we have an option of suturing the standard CTR to the sclera if segmental CTR is not available. If the patient is left aphakic, then scleral fixation of the IOL can be planned. And one must always be ready for surgical surprises in these.
सडन डेथ की हिस्ट्री इन फैमिली आपने पूछनी होती है, राइट? तो व्हाई इज दैट सो? क्यों इन स्पेसिफिक पेशेंट्स के अंदर?
These patients have not usually, but may have some vague systemic associations. For example, in cases of Marfan's, there are cardiac anomalies, and in cases of like homocystinuria, there is a tendency of thrombosis. So that is why such history should be taken. There is a chance of aortic root dilatation, mitral valve prolapse, and
it's a nice case. Just I mean, thoda sa apna point of view, ectopia lentis, very common condition, and in outdoor हम लोगों की tendency है, especially ज़कातिया हॉस्पिटल, मैं भी ज़कातिया में ही काम करता हूँ, फौरी तौर पे पेशेंट को ना देखा और उसका व्यू नहीं भी मिल रहा ना फंडस का, तो you go ahead with the surgery. So actually I would advise कि आप कम से कम, मैंने तो ये चेंज किया मैनेजमेंट, पेशेंट को एक दो दफा बुला के अच्छी उसकी रेटिनल पेरिफेरी जरूर देखें, बिकॉज दीज मोस्ट ऑफ द टाइम द यंग पेशेंट बच्चे होते हैं ये टोपिया लेंटिस के साथ, मेनी ऑफ देम, एंड स्पेशली यू टोल्ड के जो सेकेंडरी प्रॉब्लम्स हैं लाइक मार्फन वगैरह में तो सवाल ही पैदा नहीं होता ना, उनमें तो लाजमन पेरिफेरी कुछ चेंजेस होंगी. वैसे भी इट इज वेरी कॉमन कि इनमें कोई ना कोई पेरिफेरी डिजनरेशन होती है, और वो उस वक्त अगर आप सर्जरी कर भी दो ना, उस वक्त क्योंकि उनका पीवीडी नहीं हुआ होता ज्यादातर का, तो वो कुछ भी नहीं कहता, मगर इनका फिर आप जब सर्जरी कर देते हो और वो जब विट्रस में एंड मैनिपुलेशन होती है, दे कम विद पीवीडी and they come with detachment, because I have to deal with those RTs, and these RTs are very very difficult to treat. बहुत मसला होता है, तो इसलिए इनका बहुत अच्छी तरह हम लोग एज अ रूल इनकी बहुत अच्छी पेरिफेरल एग्जामिनेशन, बेशक उसके लिए ईयूए करना पड़े, वो करके उसको प्रोफिलेक्टिव लेजर अगर लीजन है ना, क्रायो या लेजर लगा के तो फिर करें. दैट्स माय इनपुट फॉर दिस केस.
Our next presenter is Dr. Momina Malik, and she's a final year resident, and she's presenting a case of anterior segment ischemia after scleral buckling. Please.
Assalamualaikum. I am Dr. Momina Malik, and the title of my presentation is When Cure Becomes the Cause, a Diagnostic and Therapeutic Dilemma. A 42 years of age male, businessman by occupation, presented to the outpatient department of LRBT Multan Road on the 16th of March 2025 with a complaint of discomfort and blurring of vision in the right eye for the past 1 year. My patient, non-diabetic, non-hypertensive, is a known case of high myopia since his childhood. He is a known case of bilateral advanced glaucoma and is on triple anti-glaucoma therapy. In 2018, the patient suffered from bilateral inferior rhigmatogenous retinal detachment He underwent buckling procedure in the left eye elsewhere, which failed, and the vision of the left eye deteriorated to perception of light. In the right eye, buckling plus pars plana vitrectomy was done, and the vision in the right eye improved to 6/12, which was considered as practically the only functioning eye of the patient. Intraocular pressure, however, was not controlled after these procedures, despite triple anti-glaucoma therapy and oral acetazolamide. The patient underwent trabeculectomy procedure in 2022, which failed. His vision gradually started to deteriorate in the right eye, which was associated with occasional pain, grittiness, and glare, and only slight improvement was noted with topical medication. In the family history, his sibling is also a high myope. The personal allergic and addiction history is unremarkable, and the patient belongs to upper middle class. Moving to the ocular examination, at the time of presentation, the best corrected visual acuity was counting finger in the right eye, whereas it was perception of light in the left eye. Intraocular pressure was 32 millimeter of mercury in the right eye and 6 millimeter of mercury in the left eye. The right pupil showed sluggish reaction. On the anterior segment examination, corneal surface disease was noted. 360-degree encircling band could be appreciated. Scarred bleb and peripheral iridectomy was present from the trabeculectomy procedure. Rubiosis iridis was noted in the inferior pupillary quadrant, and the patient was pseudophakic. The fundal examination, despite the hazy view, we could appreciate that the retina was flat, no neovascularization of disc or elsewhere was noted, and a cup to disc ratio of 0.7 was present in the right eye, whereas pale atrophic disc was present in the left eye. This is the OCT nerve fiber layer of the right eye, and as you can see, there is thinning more so in the inferior quadrant, indicating glaucomatous changes. Gonioscopy was done, which revealed normal angle and no neovascularization at angle was noted. Multiple 2 to 3 intravitreal anti-VEGFs were given to the patient in order to combat the rubiosis iridis. So what were the causes of this chronically raised intraocular pressure? Among our differentials were pre-existing primary open-angle glaucoma aggravated by the multiple ocular procedures, silicone oil-induced glaucoma, steroid-induced glaucoma, neovascular glaucoma, and anterior segment ischemia. So first of all, in order to control the intraocular pressure, we planned for implantation of the Ahmed glaucoma valve. After implantation of the Ahmed glaucoma valve, the intraocular pressure was finally controlled at an average of 14 millimeter of mercury at multiple visits. Corneal edema improved slightly, and the best corrected visual acuity of the right eye was 6/60. However, the rubiosis iridis and corneal surface disease persisted, which was thought to be secondary to the anterior segment ischemia, secondary to the scleral buckle. Systemic investigations were done, and we ordered carotid Doppler imaging, which revealed normal flow. No signs of stenosis were noted, and no signs of retinal ischemia was detected in this case. So a quick view of the timeline of the patient. The patient is a bilateral advanced glaucoma patient who had bilateral inferior rhegmatogenous retinal detachment, for which he underwent buckling and pars plana vitrectomy. The intraocular pressure was not controlled post the procedures. Therefore, trabeculectomy was done, which failed. When the patient presented to us, we implanted the Ahmed glaucoma valve, which was able to control the IOP. However, the rubiosis and the corneal surface disease persisted, which leads to the current presentation of the patient in 2026. This is the anterior segment photograph of the patient. As you can see, gross corneal surface disease can be appreciated in this picture. This is the tube from the Ahmed glaucoma valve in the anterior chamber, the peripheral iridectomy from the trabeculectomy procedure, rubiosis iridis on the inferior pupillary margin, and the patient is pseudophakic, as we can see. So now we counsel the patient regarding the prognosis, and our plan for the patient was to remove the scleral buckle, which is one of the most common causes of anterior segment ischemia in our case. This is the per-op video of the case. Peritomy was done, and the encircling band was isolated to about 12 millimeters from the limbus. Now, as we isolated the band, due to extensive suturing, we were not able to completely remove the buckle. However, we removed a segment of it, which would cause to release the tension which was exerting on the ciliary vessels. In the post-operative outcome, at 1 month post-operative visit, the intraocular pressure was 16 millimeter of mercury, rubeosis iridis had regressed, corneal surface irregularity improved, and the best corrected visual acuity was 6/24 in the right eye, and the retina was stable. This is the post-operative picture and the video. As you can see, there is marked improvement in the corneal surface, and the rubeosis has almost regressed in this case. This is a comparison of the pre and the post buccal release of the patient, and you can see the marked improvement in the corneal surface as well as the rubeosis which was present. Moving to the literature review, intraocular pressure elevation, either transient or sustained, is a common complication associated with retinal surgeries with an incidence of about 19 to 28%. When intraocular pressure is uncontrolled medically, surgical management is considered. However, trabeculectomy becomes challenging in a post-buccal scarred conjunctiva, thereby making glaucoma drainage devices a better alternative. Anterior segment ischemia is a rare and almost forgotten complication following scleral buckling with an incidence of just 0.02 to 1%. It results from compromised anterior segment supply, primarily involving the long posterior ciliary arteries and less commonly the anterior ciliary arteries. What is the mechanism? It is caused by mechanical compression of the ciliary vessel, extraocular muscle manipulation, circumferential buckling, and circling bands which cause increased intraocular pressure, reduce ocular blood flow, and compress the ciliary circulation. Keratopathy, Descemet's fold, and corneal edema are usually the initial signs. Iris necrosis and cataract formation may begin on the side of greatest hypoxia. What could have been done is that although the diagnosis is clinical, optical coherence tomography angiography has been used to detect the iris filling defects. And the most important advantage is that it gives quantitative iris vessel density values, which can be compared pre and post-operatively. The conclusion is that retinal pathologies after glaucoma surgeries and glaucoma after retinal surgeries occurs more commonly than we anticipate. Careful and long-term follow-up is required for the patients in order to timely detect and manage all the red flags to ensure a favorable visual outcomes for the patient. Thank you.
इन्वर्स हाइपोपिया ने तो इस सिलिकॉन ऑयल रिमूवल कब किया
सर वो सिर्फ डिफरेंशियल्स के साथ ही the silicone oil was removed by the time the patient presented. Vitrectomy was done in 2018 elsewhere, and after that the patient's silicone oil was removed. When he came to us,
that was done with your
no, we implanted the valve, and then we released the buccal. Oil remove हो चुका था.
आपके लिहाज से it is anterior segment ischemia.
Yes, sir. As confirmed by the marked improvement just by removing the buccal, because there was no evidence of retinal ischemia.
इसमें वैसे ना जिस तरह बड़ा अच्छा ये किया आपने कि आप जिसको कट भी कर दें ना बाद में after 3-4 years it's very difficult to find the buccal, especially जो bands होते हैं ये band तो 2.5-3.5 मिलीमीटर के जो बैंड होते हैं ये इंटरनलाइजेशन में चले जाते हैं, तो आप उसको सिर्फ कट भी कर दें तो वो काम आ जाता है. एंड सेकेंडली ये कट करने बहुत ही करके देखे भी हुए हैं, ये दे यूजुअली डू नॉट लीड टू डी डिटैचमेंट.
जी सर, रेटिना वाज स्टेबल.
रेटिना के स्टेबल है ना?
जी सर. Sir, best corrected थी. There was some degree of glaucomatous damage as well as the retinal multiple procedure.
After correction or without correction?
Sir, after correction, best corrected. Thank you. Thank you.
So, thank you, Dr. Momina, such an elaborate presentation. Enough of ophthalmology presentations, I guess. I would like to invite Dr. Mohammad Abdul Shakur, who is going to present a presentation on basic life support and its
Sir, सर ये लगा लेना.
ये स्लाइड के लिए और ये पॉइंटर के लिए स्लाइड ये पॉइंटर के लिए है और ये स्लाइड के लिए ठीक है
जी अस्सलाम वालेकुम my name is Dr. Abdul Shakur and I'm working as an anesthetist at LRBT Multan Road Lahore. This is not a new topic for you all people. It is just a basic life sport. It is typically devised for the people who know that the health terminology. They call the healthcare providers. American Heart Association give updates after every 5 years, and this presentation includes the updates of 2025. The basic life support refers to the emergency medical care provided to individuals experiencing the life-threatening conditions like cardiac arrest, choking, or the respiratory distress. And what is the goal of the BSL? BLS is a sequence of procedures performed to restore the circulation of oxygenated blood to the two most vital organs in the body, brain and the heart, and after a pulmonary or cardiac arrest, until they can be given full medical care at a hospital. This is just to remind you what is the basic difference between the cardiac arrest and pulmonary arrest. In cardiac arrest, you don't pulse, and but there is respiration. Patient is breathing, but we don't take a gasping or irregular breathing as a breathing. And pulmonary arrest is that patient is not breathing but having a pulse. Both conditions are fatal. They are medical emergencies and they require the immediate intervention. This basic life support is taught to many people, but the healthcare professionals, the standard is higher. It emphasizes the high performance teamwork, clear communication, and proficient use of the specialist equipment. एक ही equipment use होता है, but is the automated defibrillator. High performance CPR means this is not just about performing the compressions. It is a systemic approach to optimizing every second of the resuscitation attempt to maximum blood flow to the brain and heart. Time is very critical. कोई भी BSL प्रोवाइड करने वाले बंदे के बैक में ये वाली पिक्चर जरूर होनी चाहिए. It's टाइम क्रिटिकल. ये जितनी एक्सरसाइज है ये हम इसीलिए करते हैं कि 1 मिनट तक सिर्फ कार्डिक इरेक्टेबिलिटी होती है. बहुत बिनाइन एरिथमियास हो जाएंगे जब ब्रेडिकार्डिया हो जाता है, लेकिन 4 मिनट तक ब्रेन डैमेज इज नॉट लाइकली. आफ्टर 4 to 6 minutes the brain damage is likely. 6 to 10 minutes the brain damage is very likely. It's going, but after 10 minutes it's irreversible damage. अगर आप 10 मिनट के बाद CPR करके पेशेंट को बचा भी लें तो कुछ फायदा नहीं होगा, वेजिटेटिव हो जाएगा, वो लाइफ वर्थ नहीं है. मकसद हमारा यही है कि हम विदिन वो जो 6 मिनट की विंडो है उसको जाया ना करें, प्रिडिक्ट करें, उसको असेस करें और CPR इफेक्टिव करें, ताकि जब तक ACLS वाले लोग आ जाएं तब तक हम उसके ब्रेन को और हार्ट को ऑक्सीजन ब्लड पहुंचा सकें. दिस इज वेरी इंपॉर्टेंट. So taking the right action quickly and confidently can make the difference between life and death for a person dealing the cardiac arrest. This is the bottom line. अमेरिकन हार्ट एसोसिएशन पब्लिश करती है 2010 के अंदर, तो ये है कि अगर आप पेशेंट को डिस्चार्ज कर देते हैं फ्रॉम दी हॉस्पिटल तो उसके बाद भी उसको साइकोलॉजिकल और के लिए आप उसको वापस बुलाएं और देखें. उसमें 6 चेंज हैं. सबसे पहले है आपका असेस करते हैं आप पेशेंट को, इमरजेंसी को, और provide support the circulation to the heart and brain. Early defibrillation if it is required, early advanced ACLS, and integrated the post कार्डिक केयर एंड रिकवरी. ये जो रिकवरी वाला काम है ये सब अभी उसमें डाला गया है ये 2025 में. उसी की अब्रिज्ड फॉर्म है कि अर्ली आप कॉल करें 1122 को, CPR स्टार्ट करें, डिफिब्रिलेशन अगर जरूरत है आपको प्रॉम्प्ट करता है उसको शॉक के लिए तो शॉक दें. अगर वो ACLS वाले आ जाते हैं तो ACLS प्रोवाइड करेंगे. पेशेंट विल बी शिफ्टेड टू द हॉस्पिटल एंड जब हॉस्पिटल डिस्चार्ज हो जाएगा तो फिर भी आप उसको रिकवरी में वापस बुलाएंगे 1 महीने बाद, 2 महीने बाद. बेसिक स्टेप्स क्या है हमारे, ये उसमें ये है कि पहले जो BLS की जो ट्रेनिंग थी वो सिंगल रेस्क्यूअर के लिए, लेकिन यूजुअली अब ये है कि many situations में more than one person is available to do the CPR. This simultaneous choreographed method includes performing chest compressions, managing the airway, delivering the rescue breaths, and using the AED. This is done as a teamwork. By coordinating the efforts, a team of rescuers can save the valuable seconds when time lost equals damage to the heart and brain. Common acronym in BLS used to guide the providers in a appropriate and treat the patients in the respiratory and cardiac distress is called CAB-D. Circulation, A for airway, B for breathing, D for defibrillation. This is just to present in a graphic way. CAB. CAB is compression, that is CPR. A is airway, managing and assessing the airway, and breathing, artificial breathing, and defibrillation. First of all, ensure your safety. Be sure the scene is safe before proceeding, and move the person out of traffic. इसलिए है कि अगर बाहर कहीं आपको कोई ऐसा अनरिस्पॉन्सिव पर्सन मिल जाता है तो उसके लिए है, और पेशेंट अगर ड्राउनिंग में से बाहर निकाला है तो पानी में से बाहर निकाला है तो उसको आप खुश कर लें और उसको दूर लेके चलें. बेसिकली ये है कि आप पेशेंट की सेफ्टी को प्राइम पे रखें. शेक द शोल्डर्स लाउडली, उसको वो करें, कोशिश करें कैन यू हियर मी, और उसके साथ ही आप जो आपका इर्द गिर्द कोई है तो उसको कहिए कि वो इमरजेंसी को कॉल कर दे. इमरजेंसी को जब भी आप कॉल करेंगे उसमें दो चीजें आपने बतानी है. एक ये है कि आप कहाँ पे हैं, आपकी लोकेशन क्या है. दूसरा ये है कि आपके पेशेंट की कंडीशन क्या है. के स्टेप में सबसे पहले आपको अपनी कैरोटिड पल्स को फील करना है. इसमें और ख्याल रखना है 10 सेकंड से ज्यादा आपने टाइम नहीं लगाना है. नॉट वेरी इंपॉर्टेंट. यू कांट फील इट, you take it as you don't feel it. उसको अगर डाउट में है तो समझ ले कि नहीं आ रही है CPR. This is the surface anatomy of the common carotid artery. You know that it starts from the sternal angle, the this is start from here and upper border of the thyroid gland. It is through the interior border of the sternocleidomastoid muscle. Two fingers. With one hand you have to stabilize the head, and with the other hand, 2 fingers, you palpate the carotid pulse. This is very important. Understand what is the time importance for 10 seconds only. If you don't feel it, take it. You don't feel it. Okay. Then use the heel of the one hand on the lower half of the sternum in the middle of the chest. Put the other hand on the top of the first hand. The placement of the hands on the chest. Important. And incorrectly during the chest compression. Where should you place your hands? It's very important. Usually to the layman it's taught that it should be between the nipples. Okay, for a layman it may be very good, but for a care provider it should be very precise. It's usually 2 inches from the xiphoid process of the sternum. It is the lower half of the sternum process. This is the very particular. You put your heel of the hand there. Okay. This is important. Straighten your arms and press down straight. You have to press the shoulders. जो आपका जोर है वो शोल्डर से लगेगा. मूवमेंट यहाँ फलक्रम पे होगी और ये आर्म्स और चेस्ट के दरमियान 90 डिग्री का एंगल होगा. इससे आप थकेंगे नहीं और आपकी कंप्रेशन जो है इफेक्टिव होगी. और कंप्रेशन जो है 5 सेंटीमीटर, नॉट मोर देन 5, नॉट लेस देन दैट, नॉट मोर देन दैट. And the compression should be 100 to 120. This is important. It's just to remind you that not too fast, not too hard. It should be 100 to 120 and 5 to 6 centimeters. And be sure in between each compression you completely stop pressing on the chest and allow the chest wall to return to the natural position. Leaning or resting on the chest between the compressions can keep the heart from refilling in between each compression and make CPR less effective. स्टर्नम नीचे दबती है, हार्ट कंप्रेस होता है, ब्लड जब आप रिलीज करते हैं तो हार्ट रिलैक्स करता है और ब्लड वापस आता है. दिस इज इंपॉर्टेंट. आपने हाथ ऊपर से नहीं हटाने चेस्ट से, लेकिन इतना उसको रिलीज करना है कि चेस्ट वापस रिकॉइल कर जाए। आपकी कॉमन जो मिस्टेक्स हम लोग करते हैं, एक आदमी कर सकता है, उसमें यह है कि आप टू शैलो चेस्ट कंप्रेशन, इतना जोर नहीं लगा करते हैं, 100 to 120 से कम करते हैं, रिलीज द विक्टिम्स चेस्ट, चेस्ट पूरी रिलीज, एक्सेसिव रेस्क्यू ब्रेथ्स, ओनली 30 to 2 की रेशियो है, 30 compressions and 2 breaths. You should not go beyond that. ज्यादा CPR effect होता है. You should not bouncing on the chest. And rescue अगर fatigue हो जाता है, वो बताता नहीं कि मैं fatigue हो गया हूँ. You always tell that I am tired. Somebody will replace you. And stopping for the arterial pulse. Every 2 minutes you have to check the arterial pulse, not frequently. आपके CPR के बाद अगली चीज जो है कैप डी के अंदर, वो है एयरवे मैनेजमेंट। एयरवे मैनेजमेंट में आफ्टर 30 कंप्रेशन स्टॉप एयरवे बाय टिल्टिंग द हेड एंड लिफ्टिंग द चिन। कहते हैं कि आपको एक है उसको हेड को, और यहां से चिन को लिफ्ट करना है। यही चीज नॉर्मली हैंड यहाँ पे होता है, आप यहां से हेड को स्टेबल कर रहे हैं, नोज को पिंच किया। If you suspect that this patient may have cervical injury, and you can cervical injury by this chin lift method. So the jaw thrust, this jaw thrust method, you elevate the angle of mandibles and give a push to this lower mandible. This will stabilize your cervical neck. Okay, you have to scan the patient's chest, artificial breath, by pinching the nose, mouth to mouth. You can put a barrier there, रुमाल रख सकते हैं, तो ऐसी चीज रख सकते हैं, and then eye should on the chest, it should rise up, it should rise effectively 2 to 3 inches up. अगर ये rise नहीं करती तो इसका मतलब है आपका breath effective नहीं है। अगर आपके पास बैग एंड मास्क है तो दिस मस्ट गुड, और इसमें सिर्फ ये ट्रेनिंग लेनी है कि इट्स नोन एज C&E मेथड। थंब और इंडेक्स फिंगर से आपने मास्क को होल्ड करना है उसके ऊपर, और ये इससे मैंडिबल को करना है। दिस इज नोन एज सी मेथड है। तो आप देखिए ये सी है, अगली पिक्चर में ये हमने सी बनाया उस करने के लिए, और ये ई है टू होल्ड द मैंडिबल। One cycle of the adult CPR is 30 chest compression with 2 rescue breaths. Third thing is the defibrillation, which is AED, automated external defibrillator. An automated external defibrillator is a lightweight portable device. It delivers an electric shock through the chest to the normal rhythm and changes the rhythm back to normal. Different types के AED आते हैं, मतलब मार्केट में आप कहीं शॉपिंग मॉल में जाएं, अपने हॉस्पिटल में, अपने क्लिनिक्स में, तो कोई भी इफेक्टिव होता है, कुछ भी उसमें कुछ फर्क नहीं है। करना कैसे है कि टर्न ऑन द एडी एंड फॉलो द वॉइस प्रॉम्प्ट। जैसे आप उसको टर्न ऑन करते हैं तो उसमें से वॉइस प्रॉम्प्ट आती है कि जी आप इधर हो जाए, ये इलेक्ट्रोड्स, इट विल टेक सम टाइम टू डिटेक्ट इफ द rhythm is shockable or not shockable. If the rhythm is shockable, then he will prompt you to shock the rhythm. If it is not shockable, he will say it will say that the rhythm is not shockable. Okay, you have to remove all the clothing covering the chest and necessary the chest wide, because if अगर वो गीली है, इसमें से ये 2 तरह के पैड निकलते हैं, और हर पैड के ऊपर मेंशन किया होता है कि ये क्लेविकल के नीचे लगेगा और ये वाला जो है चेस्ट पे लगेगा, तकरीबन निपल और निपल वाली लोअर साइड पे। फीमेल्स में we lift the breast and we put it underside the breast. ये क्लोजअप है उसी पैड्स का, ये सॉरी
Go out. Don't disturb others. Sorry for the last word.
थैंक यू। हैं जो आपने एईडी से निकलेंगे उनकी क्लोजअप है, उस चेस्ट पैड के ऊपर ही मेंशन है कि ये क्लेविकल के नीचे लगेगा और ये जो है ये लेफ्ट चेस्ट पे लगेगा। दिस इज द प्लेसमेंट है क्लेविकल के नीचे लेफ्ट चेस्ट पे। फील में यूजुअली if breast is small you can put it there, if breast is large you can lift the breast and you can put this electrode under the breast। एरी पेशेंट है बहुत ज्यादा तो यूजुअली एडी के अंदर ही रेजर होता है, चेस्ट जो है वो साफ कर सकते हैं क्योंकि अच्छा कांटेक्ट बनता है कनेक्टिव जेल के साथ। और अगर हेरी रिस्ट नहीं है allow the AD to analyze that no one touches victim during this time to ensure an accurate reading. The AD will give you prompt on the next step based on the assessment। जब आप उसको टाइम दे असेसमेंट का तो उससे हट जाए, दूर हट जाए। इवन जो रेस्क्यूअर है जो पहले ब्रेथ दे रहा था उसको या उसको सीपीआर कर रहा था उसको भी उससे हटना है। उस वक्त पेशेंट के करीब कोई नहीं होगा। दिस ए विल असेस द पेशेंट, करेगा और प्रॉम्प्ट करेगा कि यस यू कैन डिलीवर द शॉक। अगर वो आपको प्रॉम्प्ट करता है कि डिलीवर द शॉक तो देयर इज अ बटन यू हैव टू पुश, वो डिलीवर करेगा और डिलीवर करने के बाद आप फिर दोबारा देखेंगे उसको, वही 10 सेकंड्स के लिए पल्स देखेंगे, पल्स वापस आई है कि नहीं आई है। अगर नहीं आई है तो यू विल स्टार्ट द सीपीआर, विल कंटिन्यू फॉर द नेक्स्ट 2 मिनट्स एंड रिपीट द प्रोसीजर। अगर आपकी पल्स वापस आ गई है, पेशेंट ने ब्रीथ करना शुरू कर दिया है, तो जब तक दूसरी टीम नहीं आती है सीएलएस वाली तो आपने पेशेंट को लेटरल रिकम्बेंट पोजीशन में लिटा देना है, या हम इसको रिकवरी पोजीशन कहते हैं। कैसे लिटाना है, जिस साइड पे आपको लिटाना है उसकी आर्म को फोल्ड करें, पेशेंट की दूसरी आर्म से उस पेशेंट को वहां टिल्ट करें इस तरह से, और ये वाला ऊपर वाला हाथ उसकी चीक के नीचे दे दें। ऊपर वाली टंग जो है जो स्काईवर्ड वाली है इसको फोल्ड कर दें, नीचे वाली स्ट्रेट रहेगी। दिस इज नोन एज द रिकवरी पोजीशन। ये तब है जब पेशेंट की पल्स भी वापस आ गई है और वो ब्रीथ भी करना शुरू कर गया है। जब आप वेट कर रहे हैं फॉर द हायर टीम जिसके पास एसीएलएस है या वो हॉस्पिटल की एम्बुलेंस है 1122 वाले हैं, तब तक आप ऐसे रखेंगे। ये उसी को दोबारा के साथ एक्सप्लेन किया गया है कि ये उसकी स्काईवर्ड है, इसको ऐसे रखना है, ऐसे रखना है। दिस इज द रिकवरी पोजीशन। ये अमेरिकन हार्ट एसोसिएशन की जो टोटल एल्गोरिदम्स है उसका जरा वही जो हमने डिस्कस किया कि वेरीफाई द फील सेविटी, check the responsiveness of the patient, shout for the nearby help, activate emergency response system, send someone to get the AED defibrillator. Look for breathing. If there is only gasping, or check for the pulse. If pulse is definitely felt within 10 seconds, तो नॉर्मल ब्रीदिंग है, नॉर्मल पल्स है, आप उसको लेफ्ट लेटर लिटा के वेट करें फर्दर हेल्प आ जाए। एब नॉर्मल ब्रीदिंग है आपकी लेकिन पल्स फील हो रही है तो आप एक ब्रेथ करेंगे एवरी 6 सेकंड या 10 ब्रेथ पर 1 मिनट में, और एवरी 2 मिनट्स पे इफ दोनों पे स्टार्ट सीपीआर। वो ओपिएट की है, अगर ओवरडोज हो तो फिर हम एंटीडोट देते हैं इसका। अगर आप पल्स फील नहीं हो रही तो वी स्टार्ट यू हैव टू स्टार्ट से वही 30 कंप्रेशन 2 ब्रेथ्स के, वो उसको जज करेगा। अगर शॉकेबल रिदम होगा तो आप शॉक लगाएंगे, नहीं होगा तो आप दोबारा फिर उसकी सीपीआर करते रहेंगे उसका टिल। मकसद यही है कि आपको जब तक के फर्दर हेल्प नहीं आती, यहाँ पे आप डेफिनेट एयरवे या पेशेंट के और मेजर्स हैं जिसमें आप देख सकते हैं कि आपकी इफेक्टिव है सीपीआर, तब तक उसको आप लाइफ बचा के रखें। आप उसके हार्ट को, उसके ब्रेन को ऑक्सीजनेटेड ब्लड देते रहें। ये ऑक्सीजन ब्लड विल सेव द लाइफ, यही सबसे मेन इंपॉर्टेंट काम। दैट्स ऑल। थैंक यू। जी प्लीज।
माइक चलता है, कुछ एक्सप्लेन।
उसमें इसमें कंटिन्यू कर रहे हैं जबकि ACLS वाले ना आ जाए, क्योंकि आप बेसिक लाइफ सपोर्ट देने वाले हैं, आपने 3 मिनट के बाद देखना है और करना है। ये दिल्ली छोड़ अपनी बची, ठीक है, बैक ऑफ माइंड में आपके आ जाता है, स्पेशली जो एक्सपीरियंस लोग हैं, हम एनेस्थीसिया वाले हैं, हमें पता होता है कि ये शायद पेशेंट नहीं होता, लेकिन नहीं। और बॉटम लाइन यही है, टेक्स्ट को टीचिंग यही है कि कीप इट गोइंग। बात आपकी इफेक्टिव CPR और अच्छे ब्रेथ जो है वो उस पेशेंट के AED सब ये है कि 2 रिदम होते हैं जो शॉकेबल होते हैं, बी टैप होता है, बी फीप होता है। अगर इस सिलसिले में है तो ACLS वाले आप ही उसको एड्रेनलिन देंगे और वो हार्ट फिब्रिलेट करेगा, तब आप डिफिब्रिलेट कर सकते, आप कुछ नहीं कर सकते।
जो मशीन आप रिदम के शॉक देना है,
जी बिल्डिंग होता है ना उसको ऑटोमेटिक जस्ट बी यूजेबल, बट आपके जो वो वंस यूज होता है।
जब आप एक दफा आपने शॉक दे दिया पेशेंट
नहीं वो तो आपने इलेक्ट्रोड लगा लिया, लगे रहने जब
के साथ या
उसके साथ ही लगे रहेंगे वो, जब तक कि ACLS वाले आ नहीं जाते। अगर उनको जरूरत होगी वो ट्यूब डाल लेंगे, ठीक है, और बाकी मेडिकेशन उनकी है, हम देखते हैं देनी है, आपने एट्रोपिन देनी है, आपका कंप्रेशन ताकि हार्ट को मिलता रहे, वही उसको बचाए। अगर उसको 4 मिनट 5 मिनट से ज्यादा अगर ऑक्सीजन ब्लड नहीं जाएगा, इज नॉट गोइंग टू अब सर्वाइव कर भी लेगा बाद में तो वेजिटेबल, उसका कुछ फायदा नहीं। एनीथिंग? थैंक यू।
Thank you so much. This marks the end of our presenters. And I would like to conclude one thing, that this was our first presentation of OSP. So I'm sure it was not perfect, but sooner or later we're going to reach there. And now I'd like to invite Professor Qasim Latif Chaudhry on the stage to conclude the session. Thank you, sir.
Assalamu alaikum ji. Thank you very much for such an informative and very good quality presentation today. ऐसा लग नहीं रहा कि ये पहली यहाँ पे है, because everything is very well managed and हर चीज content wise was very good, और for us even it was very informative. जो आपका गेस्ट लेक्चर था जिसके अंदर ये बेसिक लाइफ सपोर्ट है, आई थिंक ये चीजें वो है जो आई थिंक हर बंदे को गो थ्रू करते रहना चाहिए, नोइंगली आते हुए भी, बट फिर वी हैव टू कीप ऑन रिपीटिंग दिस. Now I would like to share the results for the today's presentation. First position, Dr. Momina Malik. Sir, आगे please. Sir, presentation. Sir, आगे. Sir, आगे. Sir. The second position goes to Mr. Muhammad Azizur Rahman. I must appreciate the level of discussion which his presentation generated was really good, and that is how it's supposed to be. Thank you. And the third position goes to Dr. Ali Hashim Zubair for his presentation. जी सर. I would like to invite Dr. Huzaifa bin Tahir to receive his certificate from the next, I would like to invite Dr. Abdul Shakur sir to please come and receive your certificate. And next, I would like to ask for management of Shazo for arranging such a great event here today. Uh, for next clinical meeting, it will be August 8, 2026 at Sir Gangaram Hospital, Lahore, inshallah. Thank you. Sir, closing remarks. हाँ हाँ बुके देने होते हैं ठीक सर वो बुकेज में please I would like to invite Salim Akhtar साहब to receive his bouquet. सर आगे सर आपके लिए बुके
Thank you, sir.
Next, I would like to invite Mr. Waseem Jafar sahab. Please receive this bouquet from OSP. Sir, आज vote of thanks.
अस्सलाम वालेकुम। ये क्या है? दो लगाने हैं। आज की मीटिंग का इख्तिताम हो रहा है, लेकिन अकॉर्डिंग टू एक्सपेक्टेशन इट वाज रियली अ गुड मीटिंग। बहुत अच्छे केसेस थे, प्रैक्टिकल, इनकी स्पेशली गुड फॉर पीजीज। I always say that this clinical meeting is especially for postgraduate trainees, but unluckily, they are not present in sufficient number. So I would request once again to all supervisors, बल्कि LRBT में तो मैंने आपके एडमिनिस्ट्रेटर से भी बात की थी कि जितने भी उनके पीजीज हैं उनको फ्री किया करें जिस दिन क्लिनिकल मीटिंग हो, ताकि वो उसका एडवांटेज उठा सकें। और थैंक यू वेरी मच वसीम साहब, जनाब सोहेल साहब, ये बहुत अच्छी मीटिंग रही है। थैंक्स अ लॉट फॉर कमिंग। थैंक यू वेरी मच वसीम, वसीम Shah's representative for sponsoring this meeting. And now I think it is time for Kaba. Huh? There's lunch. Lunch के लिए आप तशरीफ भेजना। Thank you very much once again.